looked at bag valve mask ventilation, and as I explained, it's a temporary fix. We've recognized that the patient isn't ventilating or oxygenating correctly. We would bag valve mask them, or ambubag them is a term often used in healthcare, until we were able to kind of come up with a solution to fix the problem, whether it's medications that we can fix the problem the patient's having. Most of the time, if we're bag valve masking somebody, we're progressing down the slope to performing an endotracheal tube intubation. An endotracheal tube intubation is where we place a tube. This is about the average size tube for an adult, 7.5 to an 8. Place this in the oral pharynx all the way back down where it sits under the epiglottis into the glottic opening at the top part of the trachea. And what this does is it's placed inside the trachea. A huge bulb is inflated once in the trachea or through the glottic opening, which can be quite traumatic to the patient. We're very cautious about how we place these tubes, and we really use a lot of delicate maneuvers, which I'll demonstrate shortly. Once this tube is placed, if you can picture the anatomy of the oral pharynx, is the esophagus is going to sit to the posterior portion of the patient's anatomical position. And at this the purpose of this bulb is to prevent aspiration. So if the patient does vomit, whether it be passively or actively, we don't get any vomitus or secretions into the trachea, which enters the lungs, causing pneumonia, which can be fatal for patients in these situations. So let me take a quick second and show you what an endotracheal tube intubation looks like with a normal patient. We're going to pretend this patient's a hospital patient with no trauma to the neck or face, and we're expecting it to be a quite easy intubation. When we're intubating a patient, we use a tool called a laryngoscope. There's two types of blades. There's a Miller blade, which is the straight blade, or a Mac blade, which is the curved blade. Most common one used often in research and with anesthesiologists is the Mac 3. It's one of the blades I like to use as well. This is a battery pack. The blade is placed, and you can see there's a light. It gives us a better view of the structures we're looking for to place the endotracheal tube. We would assess the patient, and I'm not going to get too technical with you other than just showing you an intubation, but we assess the patient for difficulty. And there's certain algorithms we look at rapidly to predict if we're going to have a difficult time with this. We'll just pretend that this is a very low difficulty intubation. So what I would do is I would prepare all my equipment first. The patient at this point is still being bag valve mask ventilated with 100% oxygen. We're trying to get the oxyhemoglobin curve, the dissociation curve, to a perfect level, so that it gives me a lot of time while I'm in there to place this tube. So the more oxygen we have in their arterial system, the longer I have to intubate. We typically try to not take longer than 15 to 20 seconds. So let me go ahead and demonstrate. We always intubate at the top of the patient's head, preferably when they're in a supine position. We're going to go ahead and place the blade always in your left hand when you're intubating. So the right-handed people always have difficulty. The blades are designed to pass the tube down the right side of the laryngoscope, all blades. We're going to go into the patient's right side, and we're going to sweep the tongue out of the way while I'm lifting toward the corner of the ceiling. I guess is the best way to do it. Got to be very, very careful of the dentures or the patient's teeth. So you have to be very delicate. And we're basically sweeping that tongue up, and we're lifting the jaw, the mandible, and the tongue out of the way to open up the glottic opening. And let me demonstrate what that looks like. And there you go. That's what an intubation would look like. So once the tube is placed, obviously the more hands you have on deck, the better. The cuff's going to be inflated in place like that. As we demonstrate outside, you can remove the stylet. Stylet is just to give you some more control, which can be bent. Some patients or some practitioners or clinicians use stylets and some don't. It just depends for me on the case. And at this particular point, we would confirm placement. So I would bag valve mask the patient. We would expect to see chest rise and fall. The patient at this point is going to be bag valve mask ventilated like this. You would bag the patient. We would use a stat cap, which confirms that we're having CO2 exit the endotracheal tube. It's going to turn gold. And what that's telling us that we're getting CO2 on the exhalation. So if we're in the stomach, then we're not going to get confirmation. We listen epigastrically to see if we hear any gurgling in the stomach, which means we've intubated the belly and need to remove that tube because we're not oxygenating the patient. And then we look at the patient's color, just use basics. If the patient looks like they're oxygenating well, they've got good cap refill, they've got good chest rise and fall, confirmed it with a stat cap, and there's many other devices we can use to confirm it. We typically will use 5 confirmations to make sure. And at this point, the tube would be secured. I would never let go of my tube until we put on a tube holder. And then we could bag the patient very easily in this situation, and then we would place them onto a ventilator. And this is what it would look like. We would remove the bag valve mask. We would take our vent tubing. The vent tubing this tube is secured now with a tube holder. And now the patient is lying in the ICU like this with a plastic straw down their trachea on a ventilator, and the RT or the nurse or the physician, the pulmonologist, would adjust the ventilator settings to the patient's condition. So that's basically an intubation. I think it's important to understand that it's very invasive. It can cause a lot of mucosal tissue damage depending on the experience level of the patient intubating, the person operating the laryngoscope. And the shorter amount of time that the patient's intubated, the better it is for the patient. You don't have that cuff pressure in their larynx or on the top of their trachea, and normally the better the outcome. The longer a patient remains ventilated on a ventilator, the less chances of survivability and the more complications typically we're going to have in the ICU.